I'm Kathy Marconi, for those who don't know me.
Mary Jordan.
Jackie Smith.
Anna Snyder.
Terry Snyder.
My name's Chris Flanagan. I just moved to Maryland.
Okay. Glad to have you.
Sarah Ramsey.
Lynn Randall.
Susan Delaney Blackett.
Okay,
And on the Zoom, can they introduce
And
themselves?
folks on Zoom, would you introduce yourselves?
I'm Paula Bell. Can you hear me?
Yes, hi, Paula.
Okay.
And Jenny and
Rich.
Rich are hiding.
Okay.
Thomas, have you figured out how to make your microphone work?
Here, I'll unmute.
Maybe not.
You did the last one.
Yeah.
So. But Trina just sent you a little note and then you just click on that. There you go. You want to introduce yourself so you're part of the group?
Apparently.
Thomas, can you hear us?
Must be unmuted.
Trina.
Oh, there
we
it is.
go. Yes,
Now we can hear you.
we heard you.
And
Hello,
hi.
Hello.
I'm Norris.
Oh, good. Thank you for joining us.
And those on Zoom can ask questions by typing in questions or
Or if you're on Zoom, you can either type a question in chat to Trina and she'll ask it, or you can just unmute and ask the question. Maybe just raise your hand so that the ladies doing the presentation will know that you have a question.
and we want this discussion to be interactive, so you can ask questions at any time.
And just remember that with any recording device, if you get little side conversations going, it will cut out the other person talking, so one at a time.
And this is Women's History Month. And that's the theme for this year, diversity, equity, inclusion. And March 8th is International Women's Day, and it's Invest in Women, Accelerate Progress. And last year, one of the themes was women telling our stories, and that's what we're going to do. Mary, you want to give a little bit about your background?
Sure. So I'm Mary Jordan. You'll hear more about how I spent my career, but the early part of the first half of my career, I was worked for a large pharmaceutical company on the business side, on the corporate side. I did a mid-career switch and started working on a public sector project, which was launched during George W. Bush, Bush 2, HIV treatment for Africa. And then I spent that time, the rest of my career working on that. And that's where Kathy and I crossed over. I knew Kathy's name. I think maybe you had heard of me. I knew Kathy, but we worked in different offices with very different assignments, and we never met till we came together to do this talk. So it's been a real gift for me to come into this and revisit and think about all this stuff, you know. Anyway.
And I worked in the local public health in Crawford, in Pennsylvania, doing health promotion and chronic disease prevention. And I did a side trip for a year on regulating hospitals and healthcare and absolutely hated it. So I went into the federal government in domestic aids, and then as President's initiative under Bush 2 started, I went with my boss to work for the White House and the State Department on this initiative. And we complement each other because my background is I'm an epidemiologist and Mary does programs, that interventions. She organizes public-private partnerships. So we both worked on the same program, but from different angles.
Right. I used her data.
And she made progress in reducing AIDS and other diseases, which we used the data from. So it was a circular relationship, which is good. This is 3 parts. I'm going to do a brief overview of the state of women in the world today in health. Then we're going to discuss probably 3 countries, if we have time for 4 countries in depth, and how they differ from us in Maryland. And finally, we're going to talk about local resources, which all of you can add to, if you're interested in working, in supporting women around the world. So, on that note,
Kathy, make sure you turn on the remote.
Yeah.
She got.
I just did. Let's try this. Oh, it is working. Okay. Let's go back.
It jumped on you.
Okay, we're going to first talk about some global health trends. Did anybody just read about the World Economic Forum that happened in Switzerland, Davos? This is a very short clip because they've made investing in women as one of their priorities for this year. So are you?
Oh, she needs her glasses.
Yeah. Well, because, it's a safety concern. Yes, go ahead. And it took me to another website.
Can she click on it again?
Yeah, it leads you to a website and then there's a video.
Oh, I remember this one you shared.
Yeah, I'll put it down.
Yep.
I went to Davos once.
It's a big deal.
It's a big deal and it was miserable because I was staff.
Oh, yeah. It is.
I was staff.
So
To
you didn't
the
sleep.
AIDS ambassador, to,
Yeah.
you don't sleep, you have to trudge through the snow. And
About Davos. Do they just talk about things or do they create programs? Do they get alliances going among different countries and healthcare providers of some sort?
Yeah.
Yes.
All that?
Yes, they,
All of you.
it's a big, big deal for the companies. On the corporate side, the CEO goes, it's a coveted invitation, that kind
Oh,
of thing. It's very, very interesting from the private side, but yes, it is any announcement, any big announcement from companies at the CEO level come from that, or, please. Go ahead.
No.
Yeah.
And the
You were
alliances
just- yeah.
that are there, for example, my boss was the AIDS ambassador and had a state level ambassador appointment, was on provided information on the first year results of PEPFAR, which was the program we worked for with the UN, with WHO, with the Global Fund to prevent AIDS, TB, and malaria. And they had a lot of talks before and afterward about going forward at a very high level.
And so when companies participate, are they expected to be measuring results and providing data back to you or to Davos or to the
The
world?
data is really the public data, and the companies feed into that is the way I would you agree with that?
Right.
Yeah, it's the public, the private sector doesn't control the data. in those
Right,
situations.
Yeah.
Davos is a place. There are
Yes.
also other forums that go on.
Right.
So it's kind of
Okay.
known. If you go to Davos for a program, it's very, very high level international. It may be healthcare, it could be economics. Free Sakari every Sunday kind of gives an update on some of this stuff. So it's,
And it's so high level, this is where the companies commit, say, you'll learn about public
Oh, so they'll
partnerships
commit to.
Absolutely.
to something, yeah. And it's fun to watch, you'd think an ambassador's pretty high level, but he was meeting with some head of state and he's had to sit for a half hour.
Yes.
And like I had to entertain him for a half hour,
Yeah.
we waited for this
Yes.
head of state.
Yes. And then I have an example recently, if you want. So one of the last things I worked on was Pfizer was gonna make an announcement at Davos that was significant for us. It was, and you'll hear about a partnership I did with them. It was very close to them years and years and years. And so they were making an announcement around, they were gonna start to sell at cost medicines that could be used, and they were beginning to make a deal with the country, at the country level. It's significant because it's very donor dependent, and you want to build the private sector. There is a private sector there, it's small and nascent, but you want to strengthen that. And that helps supply chain issues for us and for them and all of that, but worked on the announcement for Pfizer to make that announcement at Davos. So that strengthens supply chains. What they're trying to do ultimately is going to build sustainability in lesser developed countries. It's a big deal for us.
And did you have a question?
I was gonna ask if Davos was an acronym, but I looked it up and you said it was a place.
It's a
and so-
place.
And during any given year, they cover multiple topics.
Yes.
Okay.
Right,
Yes.
World Economic Forum.
Yes.
I think they just had that too, didn't they?
they just finished one.
Yeah.
Another one.
Okay, so let's look at the data.
Sorry, I had to put my cursor back for you. Oh, you're good now.
Okay. This shows global women's health trends, it's maternal mortality. And the countries in orange obviously have higher maternal mortality than the global south has higher maternal mortality than the global north. This is also true for most infectious diseases. Malaria, TB, other diseases.
Other-
Susan, you can probably go through diseases
More in the
as a
southern
medical
hemisphere.
person. Whereas the chronic diseases, they are present in Africa and South America, and they're growing, but they're the leading cause of death of the global north. So women are experiencing very different diseases in the global south.
There's probably a shorter lifespan for women in the global south as well, which would reflect the chronic diseases being more prevalent in the north.
Right. So, and this also occurs in what's called the social determinants of health, which you've probably heard of, education, economic opportunity, conflict, governance. When you look at them frequently, they're impacting women in the global south. Now, Ukraine, this year has more conflict than any year since World War II, this past year.
I would like to just point out quickly that malaria has again come back as one of the major killers, where HIV has dropped a little bit because of the work that you all did. And then, of course, childbirth, death in childbirth is still very high.
Yes.
in those areas.
I'm surprised the mortality's not higher in the Middle East.
Or Afghanistan.
That's what's up.
It probably is.
We just saw a good.
This is a couple of years old.
Yeah.
We don't have data on Afghanistan. We're going to cover Afghanistan, and the last year I could find data was really the beginning of 2021. Because after we left, the system collapsed, so. So, yeah, this is a picture a couple of years old. Now, COVID was the exception, right? Because of COVID being associated with older populations.
And there's no data for Greenland. I guess.
So you look at education trends, it's very similar. Women have really progressed in being enrolling girls in school. Completion rates have increased. The upper secondary education and the lower secondary education, and that's equal to our middle school and high school. However, over half of all children out of primary and secondary school are in Africa. And in the beginning of 2021 in Afghanistan, 60% of the girls were not in primary school. I was astounded at that figure.
Weren't they allowed? I thought they
They were
were.
allowed.
Oh, I thought they were not allowing them.
No, this is before the Taliban
Oh.
took over. Well, we were there. Neither one of us have been to Afghanistan. We both had colleagues, so I did an in-depth interview with the colleague who's worked there while the U.S. was there. He wasn't in the military. He built infrastructure for labs, for hospitals, things for water systems. And he said the divide was incredible. The women in the cities we'll get into this later, but the women in the cities were in school, they were wearing Western dress, and I'll show you later, women getting off a bus from rural Afghanistan, still in the hijabs, and it was.
That was before we left.
Yeah, before we left, and so this figure is lower now. Just to look here at Maryland as kind of anchor us as we go forward. We have 18.4 maternal deaths, which is pretty low, though Finland has 8, Scandinavia has 8 per 100,000 live births. So there's still a lot to be done. We have low HIV prevalence compared to other countries. And you can see the leading causes of death. Again, this is from 2021, I'm sorry. So COVID-19 has probably dropped down at this point as far as causes of death. But they're chronic diseases, cerebrovascular diseases, stroke, chronic lower respiratory diseases is a whole group of diseases and accidents. Our literacy rate is above 80%, and our high school graduates about 88%. And we don't count orphans and vulnerable children the way the UN does or WHO. So the nearest figures I found were, out of a population of what, 6 million at least, there are 4,000 children that are in foster care. But the poverty rate is pretty high, and I was kind of astounded. I expected it's highest in Baltimore, but it's also very high in Somerset and some of the lower Eastern Shore counties.
We actually have a fairly high percentage. We look at it from the school board perspective. About 51% of our kids qualify for free and reduced meals, and that's based on the poverty level.
And that's Talbot County.
That's
Okay.
Talbot.
was higher than that.
Caroline's pretty close to,
Caroline's higher, so is Dorchester.
yeah, I was gonna
And
say.
Somerset,
Our high school graduate in Talbot County is 96%. We really worked on getting that up.
wow.
So it would be correct to say that the literacy rate is 20% of women in Maryland are illiterate?
Okay. The UN defines literacy, and you'll see this in other figures, very simply. Can you read a simple sentence? The US defines literacy very differently. It's understanding, Trina? Understanding a paragraph, doing basic math, some other things. So this is saying 20% of the women you're right, did not achieve literacy, but it's a very different, they can read, they can do some math, they just,
I do things on their phone.
but, right,
Like maybe a seventh grade
right,
level, so to speak,
right. So we're defining literacy rather differently.
more
And
sophisticated.
Other countries, much more sophisticated.
Math and reading.
Math and reading, and comprehension, whereas the
Yeah.
other countries
Math
are
is,
just
math is
asking,
where it really slips.
can you read a sentence? Not can you comprehend it? It all gets into definitions. So these are the 4 countries. We're going to focus on 3 countries, and if we have time, we'll get to Namibia, 4th country. We picked them because we had worked there. We knew people who had worked there. So we're not covering South America, but if you are interested in South America, last week there was a wonderful talk here from the Chesapeake Multicultural Center. And most of the immigrants here are from South America, Central America, Central America and South America. So I would encourage you to, the end of the semester, the video will be online. I would encourage you to
Watch it.
watch it.
It's fabulous.
It was really interesting.
Opened a lot of eyes.
So just very quickly, and then I'm turning this over to Mary. When we came in with PEPFAR, these are figures for today. The 88 maternal deaths, South Africa is a middle-income country. But you can see, we have 18 deaths per 100,000 in Maryland. They have 88, so it's still pretty high. When we came in 2006, 7, in 2000, the maternal deaths were more than triple what they are now. The average HIV prevalence now is down to 13 or 14%, still very high. However, among the age group of 15 to 49, it's 26%. When we came in, I think it was close to 30% of the population had AIDS. I mean, generalized. It was just, AIDS can be very focused, as in the United States, among gay men and drug users. Here, it was the whole population.
Right. Whether to child transmission, you know,
And
Which is where education comes in.
yeah. TB was very high, and it still is, because of compromised immune systems. And malaria is still there.
Why was their maternal death rate so high? Was it because of lack of prenatal care? Were there other conditions, or do we know?
That's a good point. They had compromised immune systems on the women, and then there was a lack of medicines and care, especially in rural areas. There's a big rural-urban divide in South Africa. I'm sure there were other conditions, and I'm not sure what they,
Preeclampsia?
yes, that was a
So
major.
stuff that could have been prevented wasn't available.
Right, right.
access is a huge issue.
And in the cities, there are some very sophisticated hospitals, like in Durban and Johannesburg. In the countryside, there aren't. And the public health system there, physicians work for the public health system, and the pay is so low that frequently they're not at the clinics. When we came in, they were doing private practice on the side where they could earn enough money for their families. So on paper, it might look like a health center is well staffed, but when you got there and looked at it, it wasn't.
Is there a hierarchy of care? Like, do they have nurses doing some of the care that a physician could do?
It's a hard question. So you have very little infrastructure, very little. And then the proper training is also lacking. So here we would have, family nurse practitioner can handle a lot of primary care before. But the training there is very nascent and thin at best.
Yeah.
So you just don't have the educational infrastructure that feeds into all that to have like the tiered. And then you also have a lot of government regulation. It's challenging, but I don't, the availability of trained staff is a big problem.
I had a chance to go to Ghana last year. And so we went to a small village and they had a clinic there and there were 2 nurses that came in and helped with AIDS and helped with births and nutrition and that type of thing. I have no idea what the statistics were, but that's how they dealt with the rural areas.
Right.
By using nurses and like
Yes.
one of the nurses came from another community, but she moved there for that position.
Do they have like midwives that travel around?
And then the medicines are regulated, so can the nurse prescribe, and the physicians, we were dealing with the battle at the government level, wanting the nurses to be able to prescribe, but the physicians were fighting it because they felt like they would lose control of money and income, things like that. So, yeah, it's real complicated. But yes, as much, there are amazing people doing amazing things, all with very little resources. I mean, when you go there and you see this, and Kathy and I talked about this, you get back on the plane and you think, dare I complain about anything? Because what they're doing was so little and they're so resourceful. It's incredibly impressive.
No, and back to your point, when I visited rural health clinics, women walked miles to get in, just miles. So as their pregnancy progressed, they came less and less often because of the lack of transportation. So that was one of the infrastructure elements that we tried to fund was transportation
To the clinics.
to the clinics.
Which would kind of explain your question earlier, because so many health issues happen in the 3rd trimester. And then they weren't seeking help because it was so far.
Right. Yeah, it's a very good point of transportation.
So you see the literacy rate, the statistics are women at 92%. Forget about that. It's not a good measure. Whereas 52% completed secondary school, big difference between the cities, which have progressed, and the rural areas. Big difference.
Do we also have the demographics on race? Because I know there's a strong Afrikaan
Right.
English background in the South there, and then you've got the indigenous peoples and Native Africans.
I don't have the statistics memorized,
Those
but
would be
you're
very
absolutely
interesting.
right. You're right. Yeah. The poverty is associated with the lack of education, which is and poverty is associated with race there.
So you were kind of saying that 52% completed secondary school, it'd be much lower if it up to rural.
Right, it'll be much lower in the rural area. That's an average for the whole country. And in 2022, there were 2.8 million orphans. In 2011, at least double that number because of AIDS. When we came in, it was at least double.
The way USAID works is they have implementing partners on the ground. We also have mission offices. And one of my mission colleagues, the health colleague on the ground in Zambia, told me that when she first arrived, she was launching the program, they're part of, making it all happen in the pull through. She said some of the areas she went to, there was the grandmothers and orphans, and anybody sexually active was dead. Basically like they lost their parents. And then that transference of knowledge, even if it was subsistence farming, it was devastating for people in poverty, as most things are. But, the hardest people have, the poor people always have the hardest time, certainly with my experience.
Yeah, and I met a woman, one of the few women who was a researcher in Uganda, and she told me that she was the oldest woman in her 7 child family, and she got to go to school. They had enough money to send her and her brothers, and none of her other sisters had progressed beyond primary school because they didn't have the money. So the boys came first for education.
And so they have to pay.
Yeah.
All school related, yes.
It says it's free if you look, but the fees are quite large.
And they usually uniforms
Yeah,
as
the
well as
uniforms.
books.
And then sometimes the teachers are there and sometimes the teachers aren't there because they're not getting paid, you know. Anyway, it can be very uneven.
This is our only wording slide.
Yeah. And I'm not gonna, don't worry about reading this, but basically, Bush 2 launched, it really, HIV was men, women, families, children affected. It wasn't just what we consider high-risk populations of people, like you said earlier, the drug use population, and as well as men having sex with men. They were definitely hotspots of that, but really this was going on across the board with the generalized population. So Bush 2 launched, and he had bipartisan support, which is like amazing. You remember that word? And so he had bipartisan support and launched, and it was well funded. One of the keys to the success of this program, and most people agree, is that it has been well funded. So to date, the investment's around $100 billion, and it's estimated to have saved 25 million lives. So it's been quite successful. So next slide. Unless anybody wants to read it. But that's so I mentioned earlier, I do public-private partnerships. I was with a large company, did a mid-career switch, and I became the point person. USAID is the development agency behind this. There were multiple agencies involved. USAID was the development agency behind this, the global health piece of it. And I worked across the office. I was the point person for reaching out to the private sector. And the office consisted of supply chain, research division, treatment, care, prevention, and the plight of orphans and other children made vulnerable. So it was very interesting. I was never bored, I promise, and it was so interesting. So one of the first trips I made so I had the corporate side, but I didn't have the development side. So I relied heavily on the people on the ground, people in my office, the real experts. I would have an opportunity on the corporate side, and I would go to them. I went to this fabulous woman who was doing orphans and vulnerable children, and I said, okay, I have this project with Coke, and I said, how do I, what is it I need to pay attention to? And they were just great in terms of educating me. So this particular partnership we'll talk about here, I land in South Africa, the health officer there, they're building the ship as they're sailing it, the money's there, they're trying to pull it through. And she came across this program called the Mothers to Mothers program to prevent the transmission of mother-to-child transmission. And she said, is there any way you can help us? So they always asked me in price, like when they couldn't fix it, when there was no money or the money was silent or whatever, they would think, is there anything you can do? So I was always the 11th hour, fire drill kind of thing, but it was fun. So the next thing is the video. I'll first introduce you to this program and the founder, who is this fabulous man.
Arrived in Cape Town and found that I had almost stepped back a decade, that we couldn't test, we couldn't treat, and we really couldn't intervene medically in a meaningful way. The first challenge was coming from the States as a man and from another culture and never pregnant and fortunately not HIV positive. How do I connect with people who just, they don't speak my language and I don't really understand the context of the lives they're living? And I was so fortunate to have a woman, Elaine Mann, who was a translator, but also sort of a counselor. She was able to connect with patients in the most meaningful way because she too was HIV positive and a mother. And we formed a partnership in clinics, talking to patients. And I would sit with Elaine and she would translate. And I would say to Elaine, why don't you go off and explain to the mother about how to take care of her baby or how to take care of herself. And Elaine would go off and come back. And I thought, who else could do this? And that was the challenge. And the truth was, one day in the shower, the lights went on, and I thought, well, a patient could actually come back after she's had her baby and join me in the clinic and tell everybody what she's just experienced. And while I didn't have the words mentor mother in mind, it was that notion of a mother who had experienced something who could be a peer and be a mentor to someone else who was about to experience what she had just completed. And so I started to enlist my patients to come back in and be present when I was there, to be that next Elaine, to go off and to educate and to support someone who was with me. And wrote a grant proposal and got $7,000 from the Star Foundation. And that to me was a huge sum of money. And it launched the program with $7,000. And the money was in an account, and I would go after every clinic to the ATM and pull out enough money to pay the mentor mothers, the women who were with me in clinic. And that was the beginning.
No, go back. Get mine. Sorry. This is hard to do for most.
Tonight, PBS will broadcast the ceremony for the Gershwin Prize for Popular.
You're controlling it now?
I am. I'm trying to bring this back over so that we can get back to your slides.
There, now you should. Now I should.
Okay.
So what was going on, we needed tens of thousands of people covered in the education for the mothers to talk to the other mothers, influence, and to talk to other mothers about the importance of taking the medication prior to delivery. And that's what he was doing, was like, the period, pulling that in, encouraging women to come in and have the medicine prior to delivery. The challenge was, he's a physician with no finance background. We're trying to pour millions into this guy because we really, really are, wanting to scale all over South Africa. We were in PEPFAR was 12 countries on the African continent, and I traveled to most of them and working back and forth from Washington. But with this, he came to me, my colleague said, is there anything you can do? So we met, and he said, look, I'm like driving around with a shoebox in the back of my car with that, $7,000, and we're trying to like pour money into it. And this is a problem with lesser developed countries in general. Congress appropriates the money. We program the money into the proper program, what it's designated for, earmarked for, all of that. But you have to have enough pull through on the ground, enough financial fluency to do the reporting in order to pull the money through. And in lesser developed countries, that is a real challenge. And if you don't pull the money through as you should, it goes back to Treasury, and then Congress thinks, well, they don't need it anyway, right? And so you've got a finite amount of time, you've got the money sitting there, and you just are running 100 miles an hour flat out to pull the money out appropriately, properly, sustainably, with all the checks and balances in place. So at the time, Pfizer was launching this Global Health Fellows Program. And then we were beginning to work with them, but they were only seconding medical personnel. So I'm from the pharmaceutical world, and I know we have finance division, research division, supply chain division, companies have a lot of resources, right? And so I flew to New York and I met with them, and I was like, thank you very much. We're very grateful for this program. However, what we really need are finance people. Is there any way you could second finance people? And they said, sure. So it was just wonderful. So they seconded people out of their finance department to go to Cape Town. They seconded the person for 6 months instead of 6 weeks, which was huge because you get there, you get your arms around it, and you can really get some traction, and you can teach. You can have people you can mentor along the way.
So that they can continue.
So that they can continue. And they did We had that for 2 years. We had 4 people over a 2-year period. And the qualifications on the Pfizer side was you had to be there for 5 years, you had to have a proven track record. I mean, we had talent. It was just fabulous. So, and I was picking all kinds of talent out of them. You know, it started with finance, but anyway. So Mitch, Dr. Besser came back to me and said, it would have never happened. He could have never scaled without him. You know, so he, to this day, he gives Pfizer the credit for helping him scale. And now they're in multiple countries and they're covering about at least 15 million women. So my point is there's a whole business to the business side of healthcare. And if you're not moving the money, if we're not moving the money on the public side, the program's not moving. So it's bottlenecked and you're stuck. So that was the beginning of that partnership.
So getting money from the public side, is that a little like getting grant money where you have to keep providing reports back?
Oh, gosh,
to
yes.
where?
Oh, yes. And this
If
is-
they came back to our office.
Yes, yes, and accountability,
Yeah.
right.
Fiscal accountability, program accountability, you had to have a strategic plan for the next 5 years of what you were going to do.
Country
And
operations.
that, it works the exact same way in education.
Is it the
Yeah.
same as for aid? When aid is provided to the
Yes.
country?
Yes.
USA, yes.
That's what I
That's
was
what I-
thinking, that's the parallel, you can have all the money in the world, but
Or
you don't have the infrastructure to
Yeah, or you
deliver
can
it.
send all the water or whatever. that-
Well, and if you don't have staff,
Right.
you know, you can, you know, and so everything was about, the development agency, USAID, everything was about transference of knowledge, building sustainability on the ground so that when the day comes that the donor rolls out, there's something, footprint left behind at least, instead of, you know, the donor rolls in, the donor rolls out.
And if you go now, I mean, when PEPFAR started, most people looked like us.
Exactly,
Occasionally.
Right.
Now, most people are
Like that.
yeah.
like that.
You're providing education and jobs by
Mhm.
doing that in all these countries.
Oh, yeah.
And you know, it comes back to help us because Washington DC has a high maternal and child mortality rate. And they started a mothers to mothers program.
Huh, that's nice, isn't it?
They learned about what was going on.
USA.
I don't think so, but Mitch probably did.
Yeah, so it's come back to the US.
That's fascinating.
Yeah, well, and so I took this model and ran with it. And because we needed it all over the place. We needed it in multiple countries, multiple, you know, orphan programs, treatment programs.
And that's a hospital there.
Yeah, yeah.
Go on, I'm sorry.
No, that's okay. So I was thinking about stakeholder engagement, like who's got, you know, what's the business case? Because I worked on the corporate side, so I always knew if I went to my boss with a business proposition that made sense for the company, I got whatever I wanted, right? And so I was always trying to think about the business proposition. And so I went to this bank, Standard Bank, headquartered in South Africa, and with a regional reach across the continent. They weren't in every country we needed, but they were in a lot of important ones. And so I met with them and I said, look, you know, if we're not moving the money, we're not moving the program. If you're not moving the money, you're not making money off the transactions. It's stuck in the bank account, right? As they make money off the transactions. And so they looked at me with kind of one eyebrow raised. We'll see. And nobody's more cautious than banks and investment people. Nobody's more cautious than the money people, trust me. And so, so they agreed to send me one person to an orphans and vulnerable children's side. And this guy was getting ready to retire and a vice president level. So he goes to this, my colleague there identified this program they totally needed. She needed their help because they couldn't reach, but they couldn't pull the money through. And so, so this man, this individual went there, helped them with financial fluency, getting them to stand it up, and then went on the board, which was fabulous. So it was a huge success. And then with that, my health colleague comes to me and said, can we get more talent out of Pfizer? Like, we've had this commitment over here for 2 years, and you can only ask for so much, right? You've got to be real careful to not burn out your help. And so that was also part of my thinking about how do I transition to something more, another player in this. So I went to Standard Bank and I said, look, we have this treatment partner, it's very important. It was a public health hospital called Right to Care. They had opened in 2000 to treat HIV, test and treat, and they were struggling. And my colleague there said, we have to get our arms around this. They were extremely important. So Standard Bank agreed to send a person there to just put their toe in the water. And the bank was not an account. It wasn't one of their customers. It was they were banking with a competitor. And I said, look, there can be no quid pro quo. You can't, force anybody, but probably if you go help them, they might end up being new business. So, so they went, they tried, and there were no strings attached. Well, of course they decided, if these people are helping us, then we'll move our account. So it was a huge account, new money for Standard Bank. And then they got it. Their light bulb went off, right? Like, oh, yeah, we do want to work with this. And so, so as a result of that, a lot of doors, it was hilarious. The CEO flies to Washington to meet with me like I'm some big deal or something. It was really funny. But he was a very nice man. But anyway, so all of a sudden I could get all these resources out of Standard Bank, and Standard Bank is there. They want to survive. They've got to survive, and we have to survive this epidemic together. So at that point, at some point in Namibia, and this goes back to what Kathy said earlier on literacy. So this is a partnership that Standard Bank helped with, but it's a very different partnership. So I'm switching gears. So there was orphans and vulnerable children at the Angola border. Kathy's data, what she built, the platform she built, reflected that at the Angola border, it was our highest HIV incidence in that country. And so with that, State Department was funding a literacy program at that border, up to grade 7, what would qualify as a 7th grade education, but they weren't able to graduate. So I pitched at Standard Bank. I was like, I know you're helping us over here do this, but I also know on your foundation side, if you do anything at all, you'll do scholarships, and would you partner with us and graduate our girls? Well, because we were so important to them, they said yes. And so as a result, 4,000 girls graduated from that program. But that tells you the value of partnerships when it's shared value. If they were making money, they were happy, they weren't just give, and I wasn't just take. I was trying to figure out ways that it would be meaningful to them. So that's just one partnership that I did that ended up working really well. So,
Fantastic.
yeah, it was fun.
And it's programs like this that have led to that increase of literacy.
And Right to Care's in multiple countries and treating millions of people over the years.
I would love to know if any of those girls ended up working at Standard.
I know. Well,
Because I wouldn't be surprised.
In Ethiopia, which is but anyway, no, I don't know. But that is part of what in South Africa, they did have a scholarship program, and they wanted to get to vulnerable kids. So that was in Namibia, and I had my OBC colleague with me, and they were working out how she could feed the kids in our prevention programs into that. So yes, but could I document whether they were hired or not? I don't know.
So we're going to move to Malawi now, which is a low-income country. It's one of the 12 poorest countries in the world, mainly desert. It does have a lake that goes down it. It's a young population. It's a growing country, 10.48 million women. Look at the maternal death rate today. And you can imagine when we started, It was almost double that.
Wow.
I mean, the joke among the physicians in the city was that the occupation most in demand was undertakers. We got there. And women are most affected by AIDS in Africa. It's not men. I mean, there's higher AIDS rate among women. It's because it's in the general population. It's not a concentrated epidemic there. So the average prevalence today is 9.6%, which is still high, and among 30 to 34-year-olds, it's 16%. And the leading cause of death, HIV/AIDS, neonatal conditions, not just caused by AIDS, but various neonatal conditions, lower respiratory infections, cervical cancer, malaria, stroke. 36% on average completed secondary school. So can you imagine what the rates are in rural areas among women? This is among women.
Yes, wow.
And 18% today, or 930,000 children, are orphans, and that's gone down from when we started. So it's a very, very poor country with not a lot of natural resources. It has an incredible nursing physician shortage. That is a nurse angel on the upper left that was advertising the importance of nurses and staying in Malawi because there's out-migration, right? Medical personnel, any kind of educated person wants to go to a better country. And right now there's a strike going on because inflation has hit Malawi and nurses aren't making enough money to live on. So the lower left side is a rural house, and some of the rural clinics look like that too. Lower right are one of the orphan sites that I visited that the Peace Corps was about to work in. They had a couple of blankets and a ball, and all the children came every day. A ball of the village came every day to play, and they had a hut with a dirt floor to sleep in, and that was their resources. So that was our starting point for providing services.
Yes, when you say the children of the village, so the children, they didn't have, if they're orphans, were they living in these huts?
Well, orphans also can be one parent.
Oh, okay.
Okay,
It's
so
usually
they,
a grandparent.
and a grandparent.
Okay.
Yeah, so they were living in the village.
Yeah.
And they came like as daycare almost to this site. And you can see how barren it is. I mean, that's the basic countryside. And then one of the women said we were going to talk about some of the women, African women. Willetta Lema, I learned a lot from. She is Ethiopian, but she's worked across Africa. She lives in Ethiopia. Her family's from Ethiopia. She went to school in the US. A number of people I met had gone to school in the US. She realized that the infrastructure to even some of these basic clinics was totally missing. The physicians had, or nurses, well, the nurses who were there, it wasn't usually physicians, or the community workers, had no idea if the person had received any vaccinations, what their previous care was. And what she started is everybody's phones. She started medical records, trying to get longitudinal medical records so people could at least track patients because they're not full-time in these centers. They can come a couple of days a week. So she's been working on that, and she just won at a web summit an award for her work that she's been doing across Africa. So she's
Dangerous to work there?
Where? It's Willetta started a medical school, helped start a medical school outside of Addis Ababa. Is that Addis in Ethiopia. That's it, Addis. And the recent war in Ethiopia destroyed the library and half the classrooms in the school that they had just built.
But the other thing, when you work in places like that, I've only spent 6 weeks at a time, a short-term thing. They want so much to learn. If you give them basic skills, hand washing skills,
Absolutely.
hygiene during periods, things like that, they just eat it up. They're desperate for that. And the women, if you empower the women, it takes care of the men until you get into the situations where the warlords, and that apparently is what's going on there. I don't have that much knowledge about that specific.
But you're right, if you empower the women, if you educate the women, they'll bring along the children, they'll bring right, and then, so it's really key. So that's just some of the background of what I experienced in Ethiopia. I mean, in Malawi, what did I say? Malawi, okay.
So in Malawi, it goes back to that move the money, like to try to get it out to the rural areas. And I approached Standard Bank. At this point, they were real happy with me. And so I approached Standard Bank about what could we do there. And someone on their board had an accounting firm in Malawi, and they seconded accountants out to the district provinces to work beside and teach the pull through of the money for programming. So that ended up working across the country. But in Malawi, I was able to get a vice president of manufacturing that was getting ready to retire from Pfizer, went and helped in a manufacturing facility, was able to get old equipment from Pfizer to stand this up for nutrition. They could grow their own ground nuts. And we had children that were malnourished were obviously a problem. And so he was able to stand this up and get enough of the regulatory framework with the government in place for Malawi to be able to export the ground nuts to other countries. So there was so many, 1,000 flowers bloom, but it was Malawi was fascinating. And the people were so sweet. They were just so nice.
Well, and the payback for people from Pfizer retiring, what a wonderful thing to be able to do. I bet he was, and I bet he was just swelling with pride that he was able to help.
So yes, it was real. We had the most interesting people. It was great. So, and then you talked about nutrition before with the children, the grandparents, the grandmothers, because their parents were gone or had died. They would just take on 10 and 11 orphans. So when you were asking, where do these children sleep? It was unbelievable, the safety net that if the grandmother was living, the safety net that was provided there. And you mentioned the drop-in centers with the children playing. In Namibia, there's a drop-in center. There's a slide further down. We don't have to show it, but I went there, and we didn't build facilities. USAID didn't build facilities. They would just use what was there, and it was only for the afternoon, so they didn't have orphanages. It was just a safe place to go. So I show up, and there's like one piece of probably cabbage of some sort floating in this boiling water, and it was pretty awful. But that was what they were going to have. And I was able to work out something with the dairy there, and one of our partners to deliver a protein supplement that was like a yogurt type thing, which was great. But anyway, so that was fascinating.
And this is an example just of a medical building clinic in Botswana, but Malawi had very similar buildings to this. I have some photos somewhere of them, but I could not find them.
Isn't that the other challenge?
So now we're going to talk about a project. Well, Mary mentioned dreams before. Nadia Sam Agudu is from Ghana, but has worked in Nigeria and a number of other countries on dreams. The project Mary mentioned on the medical side of dreams.
And DREAMS was for adolescent girls and young women prevention program, right?
but it included education, so many other aspects.
That's right.
Nadia was my co-teacher for years at the University of Maryland from Africa. We both work from Africa. So you're going to hear a bit about the DREAMS project that she has led. And she leads now, she was the first African to receive a direct grant from NIH to an African organization, not through a US university. So you talk about building sustainability. That's the kind of thing that happens. And she's a pediatric physician who specializes in adolescents because she realized there was a gap in care.
What are some of the innovative strategies that have been
That started in the right place?
Yes.
Okay.
available in the pediatric, and by pediatric I really do mean adolescent as well. And this is not an exhaustive list, but some of those that are striking that I feel should be at least touched on. For example, the big problem of new infections among adolescent girls is not a problem isolated to one sub-region, but it's a bigger problem in East and Southern Africa. That is being attended to by DREAMS, which was established in 2016 by PEPFAR and private partners. And why I think it's working is that it's comprehensive, it's multi-sectoral, it's funded, and it's very focused. So DREAMS is in 15 countries. By now, you should be experts in the African continent. You see only one West and Central African country here. I'm a little salty about that, but I'm not going to dwell on that. But you know, really where the problem is where DREAMS is, and where the major problem is where DREAMS is. But it is really a continental problem, but very striking in East and Southern Africa. So a couple of countries that are not in that region, but most of the countries are in East and Southern Africa. So what is DREAMS doing? The core DREAMS package is really to empower girls and young women and reduce their risk of acquiring HIV. And part of how they're doing this is mobilizing communities for change, strengthening families, and then reducing risk of the sexual partners that these girls are coming into sexual contact with. What I also like about this and what I think also works is that challenges were thrown out to groups other than governments and big NGOs to really look at 6 other focus areas that were not in the core package, which include strengthening capacity for the girls themselves, for communities to actually address the problem. Keeping girls in school there's more than enough data to show that when you keep a girl in school, you reduce her risk of getting HIV significantly. Linking men who are the source of these infections largely to these girls to services so that their risk is reduced, supporting pre-exposure prophylaxis, which means otherwise known as PrEP, which means taking drugs to prevent HIV infection for those at particularly high risk, and then providing a bridge to gainful employment, and then applying data to increase the impact of the programs. And so these people have also been funded separately. And just to look at some impact of DREAMS, you can see here, I mean, this goes without saying, the number of girls, adolescent girls and young women on PrEP has skyrocketed in the communities that are receiving DREAMS funding. And that is what you also want to see. They are high risk, and therefore they should be on preventive treatment. And then looking at the impact again in communities in terms of actually reducing new HIV infections, you can see all these multiple lines are really different communities in different DREAMS countries. And you can see most of the lines are trending down. That is, the number of new HIV infections in the target populations of girls and young women are going down. It is working. It is working. In other areas, so we've looked at the adolescent girl, issues with adolescent girls, an example. Here we want to look at HIV testing and case identification, which is a particular problem in West and Central Africa. And I'm going to touch on the Bandasun tool, which is a screening tool used to identify children living with HIV. They've done it in adolescents as well as
Okay, I don't know if we need to go into the different tools DREAMS use, but you get the idea.
That was quite a downtrend in just a year.
Yeah.
Goodness.
And it's not just HIV.
children. The Bandasun
I think it's not just HIV, though that's what was measured. TB would be reduced, maternal deaths would be reduced, neonatal deaths reduced. So it spreads out the impact of a project like DREAMS. And I don't think we need to hear the rest of her talk. It's about some of the tools they've used to identify children and treat them, but it gives you an idea of just a major effort to reduce death among women and to educate them, basically. So.
Is that too soon?
Yeah. Are you ready for me?
Yeah.
Okay. So, one of the, I didn't recognize the visual because that.
Oh, I put that in last night.
I was like, the partnership, so I worked with multiple companies also that had a stake in this, and this pharmaceutical company, Gilead, they too were a wonderful partner. So they're working across the aisle. One of the divisions is also the research division in my office. They primarily handled the International AIDS Vaccine Initiative, so there's still no vaccine for HIV. There's still think about COVID and the vaccine, how fast that, all these years, we still don't have an HIV vaccine. And this division, they're just the most wonderful group of people, and they work closely with NIH and other partners. But one of the things they also pay attention to is what is in the pipeline that could be helpful. New AIDS drugs, prevention drugs, what's coming down the pipeline. And so with that, they are in contact with the researchers of other, companies. Yes, right, because we want to be prepared. That's exactly right. They're not doing the research. They're just paying attention so that we build the runway, so to speak, when the product is available, that we get it out as fast as we can. And so they were working with the research side of Gilead. I was working with the corporate side, the business side of Gilead. But with the partnership, and this is a good example of how public and private sectors can work together. The partnership, Gilead agreed, they understood the position we're in. We're in these budget cycles and you have to plan in advance, and it could be off cycle. There could be multiple challenges with the new product and trying to get it out to the end user in these countries, supply chain issues and others. They were just wonderful. They just basically made donations into DREAMS. It was real important to get the adolescent girls and young women one more tool in their toolkit. They were just really, really helpful, and that's why relationships are so important, and to build those relationships and try to say, if I had nothing else, I always tried to give them a lot of recognition out of Washington that would resonate with their bosses and that sort of thing. But at the very last, until the very last, I was working with the business side, and what we were trying to do, and I was using the platform that Kathy had built, and it's the data, like who's on PrEP, where are their sites located, what are the gaps, what are the holes, and then this managing director out of South Africa, we would have these conversations, I would say every other month with quarterly data. But the point was, why did I share that data? I wanted him to succeed, because if he succeeded, that offloaded a burden from us. Plus it helped build the infrastructure if we end up in that budget reduction cycle or whatever. I was trying to, it was in our interest for him to succeed. And so, that was just another interesting partnership that I worked on.
In terms of AID, where were you in the budget?
I didn't have a budget. I did not have, they funded me, and I, unlike the rest of aid, most people have their program money and their budget money. I didn't want it. I felt like we had enough money that I could work with colleagues and then I didn't need it. I did not need, I worked all those years. I didn't need the budget. But the reason I didn't need it is because my colleagues had it. You know, they had it. So I didn't have, I don't know if that's answering your question or not.
I think, okay, usually US aid flows to an agency directly or several agencies, and they work together or they don't work together because the money's coming, you know, the Navy, the Army, whatever. Okay, for PEPFAR, it was a new model that they have since followed in some of the other programs where all the money went to the Global AIDS Ambassador's Office in the State Department. None of it went straight to an agency.
Yeah.
The
You were in all those
agencies,
food
and I was at the, yeah, the agencies had to then coordinate at the country level that we were focusing on and come up with one plan and how much each agency got in the central headquarters and on the ground. So it took a lot of, we had the power to enforce coordination and partnership among federal agencies because we controlled the money. So for example, Mary referred to my data, it's not my data.
Yeah.
We got 7 agencies around a table, the heads of their evaluation FE groups. And we went around the room and they were all collecting different data on AIDS, malaria, and TB. They were all using different age ranges for women and men.
Who was in charge?
Right. So I had the money.
So she came from the money, so she,
So
the last word.
I do believe in coordination. So I said to them, why don't we meet? Why don't you meet? And then we'll meet until we all come up with a core set of information that we're all going to collect the same way. CDC had 200 indicators for their programs in a country. USAID had about 10, they were much more reasonable. Peace Corps had none across countries. So, and the Navy and Army were there because they had programs in the countries. They did some health work. So it was quite, they did, so we did this on the data end, but the same thing occurred on the programming end and in countries. So people had to work together. So just to go quickly to a different part of the world.
Yeah.
Sorry.
Okay.
Oh, this just shows.
The impact of PrEP.
Right.
Is that a scale?
Yes, it's called Truvada, and it's a medicine that Gilead developed. And it's pre-exposure prophylaxis, so it was intended for, like, you think about these young women. And you have to remember in some of these situations, these women don't have the ability to negotiate. Think about that. And so, so anyway, it's something they can take before.
Once a day.
You have to take it before you have to anticipate that you're gonna have sex, and you would take it prior to so you don't take it daily, you take it prior to the sexual.
And you can see the women, how much higher the rates were among women.
Yeah, the
blue line, as
It's
opposed
all
to,
women,
as opposed to the men.
right?
So men are supposed to take it too?
No. Well, no. Yes, they can. I'm sorry. They can. Yes.
It's, I think men's had it,
I'm
since
thinking.
men. I know, no, yes, both
Yes.
can take it, and it helped. It helped a lot.
Is your pointer working?
And also that this is a result of people, listening to prevention messages.
Yes.
Too.
It's back to those dreams programs that they also had training, if the opportunity arose around jobs and, just like making them less vulnerable was the whole point, whatever that took.
Is it working?
Yeah, okay. Okay, just quickly in Afghanistan, look at the maternal deaths. This is when as the time the US left. So you can imagine what they are today. AIDS is not a problem. Heart disease, neonatal conditions, and I wanted to point this out. The third leading cause of death among women is collective violence and legal intervention in Afghanistan. That is amazing.
Legal interventions.
Illegal is government's
Yeah.
intervention.
I don't like what you said.
So I think I missed this as you went through the slides. When you say 1,240 maternal deaths, are you saying the mothers died or the?
The mothers died. This isn't even child deaths, this is mothers dying. Mothers dying. The literacy rate when we left was 22.6% among women.
That's a lot of orphans, huh?
And at least 2 million orphans. We have no data that's current, okay? But use your imagination. So, Bill sent me these slides. There's a bus, women just got off, this is in Kabul, and you can see all of them in the traditional dress there from the rural areas.
Whatever progress has been made is all gone.
It's all gone.
They're back in the dark age.
They're back in the dark ages. And in front,
And just like that.
of the right-hand picture is a well where the people get water from. And in the back, see that building in the back? That's what's known as a poppy mansion. Drug dealers, drug lord.
The big building?
The big building is
on the
a poppy,
The modern one.
the modern one is a hospital. It's a poppy mansion. So you can see the discrepancy. And you know what, it all comes back, and you're right, Anna, to governance. I mean, if you don't have governance that is halfway decent, this is what you get. These are some more women working on the streets, and this is one of the towns in the mountains. And you can see why it's so difficult there to reach rural areas and why there's such discrepancies. I mean, you have to cross that mountain to get healthcare into that town.
To go over that mountain?
Excuse me?
You have to go over that mountain?
Well, through a pass or something,
Yeah.
There is a road you can see going diagonal
Diagonally, yeah.
from left to right.
Right.
Yeah, look at that. So you can see how impossible it almost is in good conditions to get services.
And it's probably not a very healthy place to go to for Americans anymore.
No. No.
And even worse now, totally male dominated society.
Right. And in fact, this next slide,
Where little boys have a gun put a work in their arms.
okay,
Oops, I jumped.
this is just about, the data shows women living near high-intensity conflicts are 3 times higher of reproductive age, have 3 times higher mortality than do women in peaceful settings. And that conflict indirectly affects survival chances of women, malnutrition, physical injuries, all things that make sense, right? So this is what, I like this. I got this off the web. This really shows, to Terry's point, what's happened in Afghanistan. Before August 2021, there was some services. The rural areas had a hard time. And what's happened now, and what could happen in the future. And in fact, in education, it's already happened, right? I mean, there are countries that have gotten ahead. Education has increased, health has improved, but there are other countries that have slipped. And COVID didn't help the slippage among women. So just some resources that we have. One is faith-based organizations, and I know Jen is involved in church in Oxford.
Holy Trinity.
Holy Trinity that has done some things
Right.
overseas. And community organizations here. The Eastern Multicultural Center, I didn't realize, serves over 7,000 migrants a year.
In our county. Well, Eastern Shore.
Eastern Shore,
yeah.
Over 7,000, and is always can use assistance. There's national organizations like Save the Children, and there's personal networks. Scott Cohen gave a wonderful talk at Oxford Community Center. I don't know if any of you know. Okay, oh, you were there, Sarah. About, he is a chef, well, he doesn't call himself a chef, he said, but he is a chef.
And isn't he the one who went over to Ukraine?
And he did kind of what Susan did, but not training. He went to a refugee camp there. It was a church that was housing refugees, and he relieved the women that had been cooking since the start of the war for the refugees, so that they could go home to their families for a little break. So it was something very temporary, but it was very helpful.
Is that the Oxford Community Center?
Yeah.
Sure fix that up.
Yeah, and just, I just came across him by chance by going to this talk. And it all goes back to your personal interests too, in your background. So we didn't try to cover everything about it. And there's some references, if you want to cover everything, a lot of other things, UNESCO.
Would you guys be okay if I shared the PowerPoint with everyone?
Oh,
so they could look at the references and watch
So
the
we,
videos?
when you get our memo later, probably tomorrow, with the video, she'll have a little handout thing, just you just click on that, it goes to our Google Drive.
Yeah, you'll be able to see it.
And you can see at the end, we're not going to cover Namibia.
I wonder with the drug companies like Pfizer, which I assume has a huge international presence.
Right.
What would happen with Pfizer's help if the US gradually withdraws its assistance?
They would work with universities, there's a whole, they weren't just wedded to us by any means.
Well, to put it another way, it looks like part of their interest may be they want to be cooperative with their regulatory body, namely the US government.
Yes.
So if the US government said, we're not interested anymore, would it be enough for other countries to be interested? In other words, how charitable are they really? I guess is what I'm getting to. Would they still want to fund all these efforts in other countries, non-US countries?
The fellows program?
Through no, I just anything, would their interest just go, because it wouldn't be in their.
So the way,
PR interest.
forgive me if I don't quite get, so we'll get there, but, so the way that companies work primarily is, can they justify it to their shareholders, their bosses, or what, why are they getting involved with this? And what is it?
What do I get out of it?
Right, it's,
There's the business proposition that she was talking about earlier.
yeah,
And they go to a company and you tell them how this will work for them.
right. And with Pfizer, it was, they had the vaccine. Talk about, so I worked through, I just retired, and so I worked through COVID, and Pfizer had the vaccine, right? And so, and USAID was in charge, USAID was in charge of anything outside the US in these lesser developed countries. That was given to us to handle. So anyway, it was like communication coordination, that sort of thing. But basically, I'll tell you, most companies run a really tight ship. It has to be their idea. Like, I could have never sold them on doing the Global Health Fellows program. That would just, if I had approached them and they didn't have that program, it just wouldn't have happened. It had to be vetted through them, their idea, and I just got lucky, right? And that they had that talent they were willing to second. But along the way, through that channel, as their employees saw the needs, their employees went back and said, hey, we could do this and that and the other. And, so it just really opened a lot of resources. But to answer your question, like, do companies just freely give based on, whatever, not it usually is in their vested interest to do it. When I mentioned the Davos announcement, so Pfizer real interesting, but they immediately, they had to get the vaccine. So this is post-COVID now. So they had to get the vaccine out and they had built as many channels as they could and leveraged as many channels as they could. You had to have cold storage. So they built this facility in Cape Town to do the cold storage on the COVID vaccine. And so at Davos, they had invested a lot due to the COVID vaccine in the supply chain and distribution angle. So what they're trying to do with, why are they willing suddenly to sell these drugs at cost and low, to like Rwanda? Well, how do they do that and then by that sustain that's what they built through the vaccine and pull other companies into it? Like, so then the hardest thing is who's going to move first. And once a company moves, it's so much easier to get the second company. But the first company that moves, it's the highest risk, right? And so, anyway, I don't know if I answered your question or not, but it isn't, I had much more success with making the business case than the philanthropy arm of it.
Yeah.
I think though, is the US government provides the bulk of the funding for infrastructure that all these projects can build on.
Mhm.
And if we stop providing that, you'll still have some projects, but you're not gonna have.
That was Sarah's point.
And to be honest, we didn't bring this up, PEPFAR, which is the largest health aid program the US has, I think,
I think that's safe to say.
Is not authorized right now.
Right. It's in play again.
It's in play again.
Oh, of course, because we get off health budget.
No, it also needs an authorization, a legislative authorization, and there is not bipartisan support.
So PEPFAR is a government program
Right.
that
The
is
list program.
composed of, right, okay. And mind you, what's being held up is last year's budget, not this year's. This year's is supposed to be finalized in February.
But so it's the money and then it's the legal authorization.
Right.
And both of them
They
are
have to go together.
missing right now. So this, I think your question, Sarah, gets to the heart of it. I mean, in the worst case scenario, this all goes away and you're left with the Telos project, you're left, with the Salvation Army running some hospitals there.
Right.
It's all gone. And for US policy, as far as standing in the world, it's awful.
Yeah.
It's
Oh, yeah.
awful.
Well, and it was a big fear on USAID's part. Like basically what we always did, we do vaccines where you could get in and out. If the donor funding cut off, you were okay, because it was a one-time thing. This was the first time the US got into a chronic disease. And then the implications from that, the moral and ethical dilemmas of pulling out of that. Like, what are we gonna do, with the we have 25 million people that it saved lives, but we have like 20 million people that, or plus, this is an old number, that are on the medication, right? So it's a chronic disease. And so if you take them off, then do you introduce resistance and all this other stuff? So early on, the health people were like, oh my God. We were thrilled and terrified at the same time. It was just such an epidemic, you just had to go for it. So, but yes, they're always moral and ethical dilemmas. The interesting part for me was going from the moral and ethical dilemmas of a pharmaceutical company for-profit to the moral and ethical dilemmas of the public sector. So anyway.
Is there any role for the UN in this?
Oh, yeah, the UN's very active. It's a convenient, UNAIDS is a separate UN agency. And WHO, yeah.
Oh, well, yeah.
Yeah,
And we moved together. We weren't cowboys. We always wanted WHO, the buy-in from the global partners.
So, yeah, after we got the US on the same page for data, just as an example, we then met with UNAIDS and WHO, and and the Global Fund for HIV, TB, and malaria, which is we put money in, it's a multi-country, multilateral funding agency. We all got together and came up with a core set of data so that we could report information globally to the world using similar figures. And we met regularly to review what we were doing and to provide technical assistance to the countries to build up their administrative part of their health system. So, yeah, they're the convener. And what they do is they leverage money through strategies and priorities among governments, and I guess I wouldn't know the private sector, among governments to work together on efforts.
Yes, and the private sector would want to move inside that space as well.
So, yeah.
So I'm going to come back to your question, because I think, we're still all struggling with what is the incentive that the private company would do this in the first place. And, that you would invest all this money, and what does a company get in return? I'm not sure that the shareholders and the executives are looking for goodwill or good publicity. Is there a market in that company for some other drug? Is it?
Okay, Coca-Cola, I'm just talking about Coca-Cola.
Yeah.
Okay, Coca-Cola has a big distribution system in Africa.
Yeah.
Right? You've been there, you probably saw Coke stands and Fresca stands and whatever else they sell.
So that would be their incentive.
Their incentive for Coca-Cola was to get in deeper into Africa and sell more soda. So what they helped with was building wells in areas where they then got to step foot in the door for new markets.
Yeah.
I'm oversimplifying, but that was their incentive to do good in that area, was more sales of soda.
Wouldn't it also be a tax write-off?
Excuse me?
Aren't they gonna get a tax write-off
That's a
for
whole different.
money to go? I mean, I'm just thinking that might be
Well,
there.
so my background is petrochemical industry.
Okay.
And so they would go in and they would do health programs, but it was because they had operations in those countries.
And
And it was their benefit to have the people educated, healthy, those kinds of things. So they could fund it for that reason. I'm just wondering about.
There were so many interesting reasons why. So before PEPFAR, before our government stepped in and started helping, the companies were the first ones the faith-based organizations were the first ones out there, right? All, not just Christian, moderate Muslim, Jewish organizations. I mean, there were Catholic relief services, the Episcopal, the Baptist, there were multi-sectoral faith-based groups that were there unbelievably, on the ground. And then the two companies that stepped out on the African continent were Heineken and Daimler Chrysler. And they started providing treatment. And that was real dicey, because what happens if you fire that employee, you put on treatment? So they were dealing with all this stuff internally. A lot of people that were dying were skilled workforce. So the mining companies were losing people, and people with money and assets, particularly men, were away from their wives and having sex with different people, and there was a very high transmission rate with employed people that were employed, the truck drivers, the truckers, all of this. So the companies were like, oh my God. So it was affecting them in a big way, with from the employee angle, then the market angle, because suddenly everybody that was buying Coke suddenly starts dying. So it was really impacting on them in a very meaningful way. But I did have the opportunity to ask, because the whole point of the partnerships, when we had relationships, I just love these people. I mean, I'd lay down the traffic for some
Oh,
of them.
I'm not saying that people on the
No.
ground are bad,
No,
I'm
or
just
I'm
saying,
talking about the people in the companies.
yeah.
They're not bad either.
No, I know that, you can't,
Yeah, it
Yeah.
cuts both ways. But
Yeah.
anyway, what I want to tell you, the two things I found out, why did Daimler Chrysler move? And how did they convince the CEO to do this? The CEO happened to own a second home in South Africa and it was just in his face. So the other story is, why did Pfizer do it? Pfizer, the CEO at the time of Pfizer, his son was a physician practicing medicine in Kenya. And he said, Dad, you need to do a corporate Peace Corps and start.
Yeah.
So it becomes personal, it becomes all too human. So that was the beginning of that. So there are all these little personal stories that began to, but I worked inside for, many decades on the corporate side. And I promise you, most of the people I worked with were fabulous.
I know.
And you did.
I know.
And
I
if
know
they
what
could
you're saying.
do it, they would do it.
Yeah,
And so it was me trying to figure out, how did I get this, what's the narrative for them to take to their boss to get the buy-in, to get what they want?
yeah,
And that's what I was always
Yeah.
thinking.
right. It's fun knowing that right
Yeah,
approach and,
yes,
and
And then you
who's
just
got
get
the
lucky.
soft part and the
Right.
leverage.
right.
Yeah,
And then the story on Pfizer and COVID, this was real. So nobody makes money in vaccines. Everybody complains, they're making all this money. Nobody wants to get into vaccines because you end up, it's a reputational risk and you end up giving it away. And so, it's basically the biotech firms and the other people that are bought at a certain point. And Pfizer was Moderna was totally invested, but they didn't have the scale that Pfizer had. You had to have Pfizer involved in this, but, and Moderna took government money in order to scale. Pfizer did not. And so Pfizer was working with, they had invested some money in this small firm that was working on, getting traction, and it was working. But the CEO was looking at it like he's going to be putting the company at risk. I mean, you've got this global pandemic, the risk of stepping out and the reputational risk of that, how they're going to do it, how they're going to succeed. You're running a very successful company. What are you going to do with the supply lines and the manufacturing lines? It's not like you have something out there that you're not. How are you going? I mean, it was complicated. The fascinating thing to me was it was headquartered in New York. Pfizer is headquartered in New York. And he had to basically go through those horrible pictures we saw on television in order to get to work every day. And he was like, we have to do it. So anyway, there's all that.
Yeah, I was just gonna say, we're gonna lose ours.
I'm sorry.
Shortly. No, that's okay, it's been interesting.
And it's a thank you. We have some cookies for you. And there's one,
Zoom, I'm going to get them.
one is from Egypt, a recipe from Egypt, and one is a recipe from India, and they use cardamom and, how do you pronounce it? Ghee.
Oh, yeah.
And they're kind of, they're like gravia and a little less sweet than American cookies, but
Whichever
They
one you
grow
gave
on
me
you.
yesterday, we were working on the slides together.
so anyway, I have cookies here. Please feel free to take some or take some home.
Thank you, Jen.
Very good.
Yeah.